Okay, so as Ishara said, I'm Dr. Stoddard. I am a general practice obstetrician gynecologist here with UCLA. My office is across the street. So as a general practice OBGYN, I take care of pregnant women. I deliver babies upstairs here on labor and delivery. I provide contraception and I take care of women with all sorts of across the whole range of the reproductive lifespan. So from teens to seniors. So I take care of it all. But the focus of today's talk is on contraception and then specifically on long-acting contraception. So we'll start. I have no financial disclosures, so we will talk about different medical devices, but I do not receive endorsements from any of the companies that make any of these devices. So a bit of background. So this shows the typical first-year failure rates with many different forms of contraception. So as you can see, a couple using no contraception has about an 85% chance of conceiving over the course of a year. Spermicides will fail about 25% of the time, condoms 15%. Pill, patch, and ring, a failure rate of about 8%. You may say, geez, I thought birth control pills were better than that. I've always heard birth control pills are about 99% effective. And they are, if taken perfectly, birth control pills are about 99% effective. But as you can see, these are typical use failure rates. So with the way that most women take birth control pills, which is usually not perfect, the failure rate of the pill ends up being about 8%. Failure rate with Depo-Provera is somewhere down here, I think around 3%. And then with the IUDs and then the contraceptive implant, the failure rates are all well under 1%. So these devices down here in this bottom portion can be referred to collectively as long-acting reversible contraception, or LARC, and that's a term you'll hear kind of thrown around in this lecture frequently, so we figured we'd introduce it up front. And then just to get a better look at the failure rates on the different LARC methods, so copper IUD, just under 1%. The levonorgestrel containing IUDs is 0.2%, and then the contraceptive implant has the lowest failure rate of any contraceptive method in the US, and that's at 0.05%. Despite the very low failure rates with these LARC devices, they are still not the most common forms of contraception used in the US. So if we're looking, and this is the most recent data from the National Survey of Family Growth, so looking at what women in the US were using for contraception between 2011 and 2013, still predominantly the most contracepting women in the US are using sterilization, followed by the birth control pill, then condoms, and then LARC at 11.6%. The bulk of this LARC number is IUDs. That's about 10.5% IUDs and about 1% implants. And then some of the other less common contraceptive methods, including withdrawal, the Depo-Provera shot, and the ring and the patch. Interestingly, LARC use in the US has been on the rise. You can see back in 2002, only about 2.4% of US women were using an IUD or implant for contraception, and then it has increased substantially over the last decade up to 11.6%, even surpassing sort of the last time it peaked in 1982. And then you'll also notice that this is an interesting sort of distribution, right? So why were a bunch of people using IUDs back in the 80s, and why did that stop so that like sort of no one used an IUD for like 2 decades? And we'll talk about that a little bit as well during the talk. And then another important point is that, as LARC use increases, we also see a decrease in unintended pregnancies. So, which is pretty remarkable because the unintended pregnancy rate in the US has been pretty stable at around 50%. But with this increase in LARC use over the past past decade or past several years, we've seen a drop in the unintended pregnancy rate from 51 to 45%, and a lot of this we think can be attributed to the increased uptake of LARC devices. So where are we going with today's talk? So the first objective is to review the IUDs and contraceptive implant that are currently available in the US. And then we could talk a little bit about why IUDs have historically not been popular in the US. We'll also discuss safety data surrounding IUD use, and then sort of, piggybacking on that, then discussing, if IUDs are safe, are they safe to use in adolescent or teen women as well? So to bring it way back, what is an IUD? So IUD stands for an intrauterine device. So you can see one here. It's usually, all the ones available in the US are T-shaped, although in other countries, oh yes?
It's more comfortable, that one or the rubber one?
Well, so there isn't a rubber one. So no, so they're all T-shaped, and so some contain copper. So and this one here is shown with copper, and then some are just plastic and then contain hormones. And we'll talk about the two types in a couple of slides here. But in other countries, or historically, they've been different shapes, so rings, loops, different interesting concoctions here. But all of our current iterations are T-shaped. So they're placed in a doctor's office. It's an outpatient procedure. Downsides of an IUD, and I think we get into this a little bit here. There is some pain associated with insertion. There's a small risk that as the provider puts the IUD into the uterus, that it might poke a hole in the wall of the uterus. This can usually be controlled for by providers' experience as well as use of ultrasound guidance. Both of these will help to lower the risk of perforation. And then there's also a risk of expulsion. So anytime you put an IUD into the uterus, there's about a 5% risk that it could fall out from below. And that kind of varies on various risk factors. But the benefits of IUDs are that they offer highly effective, long-acting, reversible contraception. It can be done from a doctor's office. The contraception that the IUDs offer is on par with sterilization, except reversible. Any other questions so far? Okay, we'll keep going. So what IUDs are currently available in the US? So there are 5 IUDs that are currently available on the market in the US. And if I'd given this talk only 4 years ago, it would have been only 2. So the ones that have been out the longest, there's the copper IUD, the brand name is Paragard. And then there's the Mirena IUD, which is a levonorgestrel containing IUD. The other ones down here are also levonorgestrel containing IUDs. They are more recent additions to the IUD choices that are available. So Liletta is effectively a generic form of the Mirena, and then Skyla and Kylena are part of the IUD family from I believe it's a Bayer that makes the Mirena IUD. So they're kind of new iterations on different variations on the Mirena theme from the Bayer pharmaceutical company. So the copper IUD. So it's been available in the U.S. since 1988. It's FDA approved for 10 years of use, although it is used off-label in Europe for 12 years. So we know that it can provide contraception beyond the 10 years that it's approved for. And its primary mechanism of action is copper ions, which are thought to alter sperm motility and viability. So the idea is sperm, get up to the uterus, but then, there's in the force field of the copper IUD, they can't get up to the ampulla of the tube, which is where they need to go for fertilization. Benefits of a copper IUD, so it's long-acting, it offers long-acting contraception, 10 plus years. It is non-hormonal, which some women are looking for in their contraceptive method. And because it's non-hormonal, it's safe with almost all medical conditions. Side effects, so it is associated with heavier and crampier periods, and particularly in the first 6 months following insertion. So you may ask, well, how much heavier and crampier are these periods? So here's a little bit of data for you to kind of get into that. So this is a study looking at women prior to copper IUD insertion, and then at 1 year following IUD insertion. So you can see their average period length prior to copper IUD was about 4.8 or just under 5 days. At the 1 year time point post IUD, that was now about a day longer at 6.1. Their average blood loss with the period went from about 60 milliliters, which is about a quarter of a cup, to 90, which is just over a third of a cup. And if you use these error bars, it could be almost double, but still over the course of 6 days, not a large blood loss overall. And then even though they were having slightly more blood loss with their periods, their average hemoglobins only decreased slightly. So from 13.1 to 13, which is all soundly in the non-anemic range. In this particular study, they didn't find any difference in pain scores in women prior to the IUD and then at the 12-month follow-up point. Questions? You good? And then to talk about the expanding family of hormonal IUDs that are now available in the US. So as I mentioned, it all started with Mirena. So Mirena was the original hormonal IUD that came on the market in 2000. All of the IUDs, all of the hormonal IUDs contain levonorgestrel. Skyla was the next one to come out in 2013, I think. And one of the reasons for coming out with Skyla was because one of the downsides of getting an IUD is that it's painful to insert. And so everyone's trying to come up with a easier way to get an IUD in. So one of the thoughts was, well, if we develop a smaller IUD, perhaps it would be less painful to put in. So the Skyla IUD is slightly smaller than the Mirena IUD, and as such, it contains slightly less hormone. And since it has slightly less hormone, it works for only 3 years rather than 5 years. The downside of that is that in every study, it was just as painful to get a Skyla in as it was to get a Mirena in. So although it's smaller, it hurts every bit as much to put it in. And then the downside is it really only is going to offer you 3 years of contraception rather than 5. Now, if you happen to know you only need 3 years of contraception, maybe that's a great fit for you. But for most people, I tend to counsel, why not get the one that works a little bit longer? You never know, and that way you have extra birth control if you need it. Liletta came out in, I think, the following year, so maybe around 2014. And again, this is a generic version of the Mirena, essentially. It's very similar to the Mirena, and we have a chart that goes through more of the specs on all of these IUDs in a couple of slides coming up here. And then Kylena is the most recent addition to the progestin IUD family, and it is sort of a hybrid, I guess, between Mirena and Skyla. So it's slightly smaller than the Mirena, but it has slightly more hormone in it, so it can be used for 5 years rather than 3 years. Oh, and here's the chart. Here we go. So, well, actually, let's talk about some other stuff first, so then we can go back to the chart. So all of these hormonal IUDs work by thickening cervical mucus. They actually, and I meant to put in the actual percentage here, but most of the time they're not actually blocking ovulation. So it's blocking cervical mucus, which is preventing sperm from getting up to the uterus and fallopian tubes where they need to go for ovulation. And they're also keeping the lining of the uterus very thin, which is resulting in shorter, lighter periods for pretty much everyone that has a progestin-containing IUD. So when you're looking at the benefits of a hormonal IUD, it actually has a lot of non-contraceptive benefits in addition to the long-acting contraception that a copper IUD would provide. So one of the key benefits with all these progestin-containing IUDs is that there's decreased menstrual bleeding. And then also that there's decreased pain with periods. So for Mirena IUD, there's about a 90% reduction in menstrual bleeding at the 1 year time point. And about 20% of women at the 1 year time point will no longer be getting a period. So because it's so good at treating heavy bleeding, and pain with periods, it can be indicated for treatment of fibroids, as you were mentioning, and also for treatment of endometriosis. Some of the downsides of the progestin-containing IUDs, however, are bleeding irregularities. So because it does contain hormones, it's much more common to have irregular bleeding, particularly in the first 3 months after one of these devices is inserted. So it's really important in our counseling for patients that we tell them, we're putting this IUD in, we expect you to have a decreased amount of bleeding overall. Hopefully, you might not even get a period once you've had it in for a little while. But for the first 3 months it's in, you're going to have some irregular bleeding and some irregular spotting, and to counsel them that's normal. There is a temporary increased risk of ovarian cyst formation. I believe that's about 8 to 10% of women can have that happen, but it's only for the first, I think, 3 months after insertion. And about 6% of women receiving, and this is data from the Mirena IUD, experience flares and acne. And again, it's kind of hard to tease out if that's from the device itself versus some people are transitioning from other contraceptive methods such as birth control pills, which can be helpful for conditions like acne. And then we'll go back to this chart. So this kind of gets into more of the specifics of the different IUDs that are on the market. So this column here, we talked about, who came out when, and then the total amount of hormone, which in all of these cases is levonorgestrel. So Mirena and Liletta are the same at 52 milligrams total. Skyla being significantly less at 13.5, and Kyleena somewhere in between at 19.5. And then the daily amount of hormone that's released. So the way that works is that the shaft of the IUD, it's a hormonal reservoir, and then it has this high-tech porous membrane where only a certain amount of the hormone is able to come out in any given day. So it's kind of like a controlled release that allows the hormone to come out over the duration of the life of the device. And these numbers actually do fall with time. So Mirena, that's the average daily dose, I think maybe at the 1 year time point or initially after insertion, but we know that level is actually much lower as you get out to the 5 year time point. And then it talks about rates of amenorrhea or not getting a period anymore. So Mirena is the highest at 23%. And then when you have less hormone, you have less of a chance of not getting a period. So Skyla is down here at 12%. And then both Kyleena and Liletta coming in somewhere in between. All of these devices are very effective at preventing pregnancy, so all are over 99% effective. And then the duration of use is here. So 5 years for Kyleena and Mirena, and then 3 for Skyla. Liletta, because they were interested in getting the IUD on the market, was initially only FDA approved for 3 years because that's the data that they had available at the time. It's since been approved for 4, and eventually they will have the data to show that it's effective for 5 years. So that is forthcoming, but it's expected to be similar to the Mirena IUD. Questions about hormone-containing IUDs? Yes?
If you go back to the last slide,
Yeah.
why they added the silver ring on Kyleena?
Yeah, that's a good question. I don't know. I think it might actually be, so if you have someone who has one in and you're not sure what type of IUD it is, like on an ultrasound, then you'd be able to get a better idea. So for differentiating, so when someone's not sure, you could be like, hey, okay, it looks like a Mirena, but it's got the silver ring, so it's probably either Skyla or Kyleena. And then I believe because I believe Skyla and Mirena both have the same color threads, these kind of like black threads, but then the Kyleena now has blue threads too. So I guess if you see silver ring plus blue threads, Kyleena, silver ring plus black threads, Skyla. So you can do the whole little, math in your head of exactly what's in there for people that don't remember what they had inserted. Any other questions? Hormonal IUDs? Okay. And then sort of the next contraceptive device that falls under this category of LARC is the contraceptive subdermal implant, or Nexplanon. So this is a single rod. It's about 4 centimeters, it's 4 centimeters long. That's inserted subdermally, so just underneath the skin on the upper side of the arm. And again, similar to the technology of the progestin-containing IUDs, it has a porous membrane that's releasing a small amount of progestin, and then the one in this case is etonogestrel. This device lasts for 3 years. It has mechanisms of action similar to the IUD in that it thickens cervical mucus. This one actually is better at suppressing ovulation than many of the IUDs are, and also thins the endometrial lining. The next one has the lowest failure rate of any of the contraceptive devices at 0.05%. One of the sort of annoying side effects of Nexplanon can be irregular bleeding and spotting. So to talk a bit about insertion, and I have a fake Nexplanon arm here with an implant underneath it if anyone wants to palpate. It seems like this feels fine. So there's a little rod under here. So it does need to be inserted by a healthcare provider. It's a quick procedure in the office. We use a little bit of local anesthetic, and then use a little, it comes preloaded in a little inserter. The most common side effects are bruising, and then and soreness, and then removal again is a easy outpatient office procedure. We use a little local anesthetic over the tip of the device under the skin, make a small skin incision, and we're able to remove the implant. So we mentioned abnormal bleeding being one of the side effects of it says Implanon, but Implanon or Nexplanon. So about 22% of women with a contraceptive implant will have amenorrhea, meaning no period. The majority of women will have infrequent bleeding, but frequent bleeding or prolonged bleeding, can be a problem for some women. On average, the total number of bleeding and spotting days will be less than or equal to the number of bleeding days that women would have had in a natural cycle. So in about 75% of women, that's the case. Does that make sense? So most women end up having less bleeding with the implant in than they would have having their normal cycle. However, for the 17% here with the prolonged bleeding, many of them do end up discontinuing the device. All right. So that concludes the review of the LARC devices. Any other questions? I do have some little samples of IUDs up here if people want to see them, touch an IUD while you're here. Full experience. So then I thought the next thing we could do is maybe talk about why IUDs haven't historically been so popular in the US. So that we had this figure from earlier in the talk. And so as we can see, back in 2002, I guess way back in 1982, 7% of US women were using an IUD for contraception, and then that fell down to 2.4% in 2002. So what happened in those years that caused women to stop using the IUD? And the main culprit here is a bad IUD called the Dalkon Shield. So the Dalkon Shield was released in 1970, and the problem with the Dalkon Shield was its strings. So the IUD goes up inside of the uterine cavity, which is the sterile place, but the strings go down through the cervix and into the vagina to allow a provider to remove it when the time comes. And so the problem with the Dalkon Shield is that it had multi-filament strings. And with these strings, bacteria from the vagina were able to crawl right on up into the uterus and cause infections inside of the uterus. And this was a bad device, and a lot of women got sick. And so it definitely increased the risk of PID, which is pelvic inflammatory disease. It was associated with septic spontaneous abortions, so causing not just miscarriages, but miscarriages in which women, became very sick and died. And there was a big class action lawsuit, and they stopped making this device in 1975. And because it left such a bad sort of taste, in the U.S. market for IUDs, there was then no IUD available on the U.S. market from 1975 until 1988, which is when Paragard came out. And so even though Paragard came out in 1988, women were really reluctant to take up IUDs again because, there was sort of this, collective unconscious, and not just in women, but really in healthcare providers as well. I mean, I went to medical school in 2002, and still the counseling at that time, as I was starting medical school, was that IUDs weren't, something that you could use in women that haven't had children yet, right? So IUDs were okay for women that had their babies and their family was complete, but really you didn't want to put an IUD into a teenager. You didn't want to put an IUD into a woman who wasn't, hadn't completed her childbearing, because there was this increased risk of infertility, increased risk of pelvic inflammatory disease, and increased risk of ectopic pregnancy. And what we know is actually none of this is true, and we're going to talk about the data sort of surrounding that in these next coming slides here. So the Dalkon Shield did cause infertility, and so these are some of the studies here that showed that. So both of these are different studies from the New England Journal that were published in 1985. And an odds ratio is sort of a statistical measure where it could show if something is, I guess, more or less likely to happen, right? So if an odds ratio is less than 1, there's less of an association, and if it's more than 1, and particularly the higher the number is, the stronger that association is. So there was an odds ratio of 6.8 is a pretty increased risk between infertility and in women that had used a Dalkon Shield. And then you could see that, they also showed infertility risk in any woman who had used an IUD. But again in this study, so a strong association between infertility in women who had used the Dalkon Shield, but sort of damning evidence for IUD use and infertility overall. And then sort of the next good study to look at this, again in the New England Journal, is Dr. Hubacher. So he did and both of these studies were kind of small. They had maybe like under 200 women in them. And as you know, medical studies, the more people have in them in general, kind of the better. So he did a study, and now he looked at 1,800 women, and what he's looking at here is whether or not infertility is associated with copper IUD use, or can we tease out other factors that might be associated with infertility, such as a history of STD, like maybe chlamydia. So Dr. Hubacher's study showed that copper IUD use was not associated with tubal occlusion. So here's your odds ratio. If you've had a prior copper IUD, you have no increased risk of infertility. But if you've had chlamydia in the past, you definitely have an increased risk of infertility. So that kind of cleared the good name of the IUD, showing that IUDs weren't the culprit for infertility, but prior history of sexually transmitted infection, such as chlamydia, was. And then here's some other data looking at fertility rates in women after stopping IUDs. So IUC is intrauterine contraceptive, so essentially the same as IUD. OC, oral contraceptive, diaphragm, so a barrier method, and then this is other methods. But as you can see, these curves are similar, right? No significant difference in return to fertility in women using any of these different contraceptive methods. So the first accusation is that IUDs cause infertility, and I think we have pretty good data that shows that they don't. So the next accusation is PID, and definitely the Dalkon Shield did cause pelvic inflammatory disease. But what about our modern IUDs? So there's been a lot of different studies to look at this, and sort of the take-home point from all of this is, for a woman who has an active cervical infection at the time of insertion, there is a small risk that by putting an IUD in, you could be spreading that infection from the cervix up into that sterile space of the uterus. But the rate of PID following IUD insertion is overall very low, so 0.5%. And then particularly if you are screening for gonorrhea and chlamydia at the time of insertion, you can help offset this risk of infection or particularly pelvic inflammatory disease following IUD insertion. And then the question is always, well, if I have an IUD in place, am I going to be more likely to get an STD or PID? So once you have your IUD in place, this does not make you any more likely to get gonorrhea or chlamydia or any other STD. Still, you should use condoms to prevent, sexually transmitted infection. And then even if you do get an STD with your IUD in place, you are not any more likely to get pelvic inflammatory disease than someone who does not have an IUD in place. And then the last accusation is a risk of ectopic pregnancy. And so for this, there's some weird statistical measures we use in we talk about contraception sometimes, but this is something called woman year. So this is per 1,000 woman years. So these measures are 1,000 women over the course of a year. It's sort of the best way to think about it. And I guess we should back up to say, so IUDs, if you do get pregnant with an IUD in place, there is an increased risk that could be an ectopic pregnancy. However, IUDs are so effective and your chances of getting pregnant with an IUD in place are so low that your chance of getting an ectopic pregnancy are in fact overall reduced. And so that's what you're seeing here with these numbers of 1.2 being your risk of ectopic pregnancy without an IUD in place. So by getting an IUD, you have a lower risk of ending up with an ectopic pregnancy. Does that make sense? Makes sense. Good. I'm trying to clear the good name of the IUD here, right? So myths about IUDs, that they cause infertility. Well, we know that's not true. The Dalkon Shield did. Our modern IUDs don't. That they cause pelvic inflammatory disease. They don't. I mean, there's a very small increased risk around the time of insertion, but if you are a low-risk person, that should not be of concern, and then particularly no increased risk once you have the IUD in place. And that they cause ectopic pregnancy. They don't, because in general they protect you against pregnancy, and if you're less likely to get pregnant, you're less likely to get an ectopic pregnancy. So we're myth busting here. We've busted these 3 big myths associated with the IUD, and so by clearing these first 3 myths, we kind of make way to clear the other 2, which is that IUDs can't be used in women who haven't had children, and that they can't be used in teenagers. So as IUD use has increased in the U.S., then people have sort of come around to this idea that, if these new IUDs that we have are, so safe and so effective, perhaps they are safe to use in teens as well. And so there's actually a couple of position statements on this. So ACOG put theirs out in 2002. So ACOG is the American College of Obstetricians and Gynecologists, so the big U.S. organization for OBGYNs. So they say that intrauterine devices and the contraceptive implant should be offered routinely as safe and effective contraceptive options for all nulliparous women and adolescents. Nulliparous means women that haven't had children. And then the American Academy of Pediatrics followed 2 years later, stating that LARC methods should be considered as first line for adolescents. So this is big doings, because this is helping to get the word out to physicians that these devices that are super effective for contraception are safe to use in teens. And that's relevant because teenagers do have sex. 70% of young women have sex by age 19. 90% of sexually active teens will become pregnant if they are not using a method of contraception. Teenagers are more fertile than the average population, because the average is 85%. And yet, teens are more inclined to have unprotected sex or underprotected sex than their non-teenage counterparts. So 68% of females and 80% of males use a condom at the first time they had sex. So in many ways, teens are the ideal candidates for LARC devices, right? So they have the longest amount of time between when they start having sex and when they're actually planning on starting a family. So they can actually get a full 10 or more years out of their LARC device. And it's also, when you have a LARC device, decreases your chance of having user error, right? You don't have to remember to take a pill or change a ring or change a patch. And that's why LARC devices are so effective. So it would provide a contraceptive method with lower risk for user error. And it kind of, and this is the way I help to explain it to teen patients in the office, but it makes non-pregnant the default state, or it provides pregnancy insurance, right? You don't have to think about it. You don't have to be like, oh, well, I'm not in a relationship, so I'm not going to be on the pill now, but then, maybe I'll restart it again once I, start having sex again. It's in there. You don't have to think about it. You're not going to get pregnant if you don't want to be. It's that simple. So do adolescents want LARC? We think it would be a great fit for them, but do they want it? So there was a big contraceptive study in the city of St. Louis where they got some funding to give out free contraception to any women who lived in the city of St. Louis. So in this study, which had almost 10,000 women total, they did have just over 1,000 with the adolescents, so that's age 14 to 20, women that enrolled. And LARC uptake in this group was 62%, which is significantly higher than 3.6% that it was nationally at the time the study was going on. LARC uptake in teens now is probably a bit higher. I think it's closer to 7%. And what they found is that the younger teens, so 14 to 17-year-olds, were more likely to choose a subdermal implant. And then older teens, so women 18 to 20 years old, were more likely to choose an IUD. And so of this figure of 62%, I believe about 40% overall was IUD use, and then 22% was implant use. And then importantly, also for these teen women, they showed that these women had high satisfaction and continuation rates with their LARC devices. So it just shows that if you remove, some of the barriers to contraception, and particularly if you're able to get teens in touch with physicians or other health practitioners that are enthusiastic about giving them long-acting, contraceptive devices, that, they're able to get them and be happy using them and keep using them. That's my whole talk. That's it. What other questions do you have?
So what happens if you have a Miranda and it's been 5 years and you forget?
Well, good question. So I said that Paragard was, FDA approved for 10 years, but, it can be used off-label for 12. Same thing with Mirena. So Mirena is FDA approved for 5 years, but we know that it can still provide contraception out to 7 years. So it's not like I have to remember to the day that I got my Mirena in, because in exactly 5 years from now it's going to expire. You actually get quite a lot of leeway on that. Yeah. Yes.
Is there a reason why on your side of the chart's about 1.5, but it's less hormone?
Yeah. So I don't know the whole rationale there, other than I think that, so Skyla only lasts for 3 years. So I'm supposing that, and I think part of the way, since I'm, when I counsel people in the office, it's always been like, well, why get a Skyleg when you can just get a Mirena, right? So I think what they're trying to get at is oh, well, it's a slightly smaller IUD, so maybe it'll hurt less to put in. It won't. But then it'll still offer 5 years of contraception. Oh, and then the other thing is, some people like the idea of having the lowest amount of hormone possible, right? So there's this camp of people that are kind of anti-hormone for whatever reason that they have. But they are not really a good match for a Paragard IUD. They kind of have pretty heavy, pretty crampy periods at baseline. So there really would be a better match with a progestin-containing IUD. So I want a progestin IUD, but I want the one with the lowest amount of hormone possible. So that's this weird subset of people that kind of fall into getting Skyless. And so I think that, Bear is probably let's get people that want an IUD. It's a hormone IUD, but it's a low hormone IUD, It's the low estrogen of IUDs. Yes.
I'm curious, I stopped having my period now,
Yes.
and I'm 45 now. So is this good for me?
Well, so if you're no longer getting a period, then and we'd have to do a whole workup, but then you're probably no longer at risk for pregnancy. So if you don't need it for contraception, that's one less reason to have an IUD. But there is a subset of women that will use IUDs sort of in the perimenopausal transition time, and even as they get into menopause. And the reason that they would do that, so that's going to be your progestin containing IUDs. Reasons that women use it in perimenopause is because as people are going through that menopausal transitions, periods tend to be irregular, and when they do come, then they can be quite heavy. So by having a progestin containing IUD in place, that can help people to have shorter, lighter, less frequent bleeding. So it helps to offset some of that heavy irregular bleeding that's associated with the menopausal transition. And then the other reason, I think we were talking about this before the lecture, that some women will have Mirena IUDs in during menopause as part of hormone replacement therapy. So if someone's on hormone replacement therapy and they have a uterus, they need estrogen, but then they also need progestin as well. And so the Mirena or any of the progestin-containing IUDs can then work as the progestin delivery system. The alternative would be to take an oral progestin. So people like it because they already have to do one thing to get their estrogen. They're either doing a patch or a pill. But this way, that's one less pill to take, right? It's just in there, continuous release, one less thing to worry about. Yeah, go ahead.
So it sounds like you're saying the IUD would be good if you were menopause.
Yeah, it actually ends up being, so it's great for young women, which was sort of like the angle I was trying to take with this talk, which is, IUDs are great for teenagers, and they're great for reproductive age women, and they're also great for the menopausal transition because they really help to decrease the amount of abnormal bleeding that's associated with that time. And then you could keep using it right through menopause. If you end up needing, estrogen to control hot flashes or other symptoms, just keep your IUD in, Basically, unless you're pregnant, it's great to have an IUD in place. Take it out, get pregnant, put it back in. Yeah. Any other questions? Oh, yeah, go ahead.
About the treatment for fibroids.
Yeah.
Has it been shown just to stop the growth of fibroids or actually shrink and
Ah, great question. So it will not shrink and decrease your fibroids, right? So what it will do is decrease the amount of abnormal bleeding associated with your fibroids. So if you are a reproductive age woman with fibroids, you can get a progestin containing IUD and it will help alleviate your symptoms temporarily, right? But it is not gonna completely solve your fibroid problem. Like your fibroids it's going to help with the bleeding, but the fibroids are going to be there, and it's not going to make the fibroids go away. Other things would be needed for that. But it's better for fibroids as people are in that menopausal transition, right? Because if you're in your 40s and you have fibroids, well, maybe it's only 5 more years until you're menopausal, right? So if we could just throw something at you to get you through the next couple of years to decrease the amount of bleeding and symptoms you're having from your fibroids, then you're going to hit menopause, your periods stop on their own, and then the symptoms that you're having from your fibroids are going to decrease. That's the bleeding symptoms. Fibroids can cause other symptoms as well, so it really just helps with the bleeding symptoms.
endometriosis?
Yeah, so the progestin-containing IUDs are very helpful for endometriosis, and we have a couple studies that show that. And part of that is because you have less frequent periods with a progestin-containing IUD in place, and they're shorter and lighter. So if you're not getting a period as frequently, then your endometriosis isn't going to be sort of reactivating as frequently. It helps to keep everything calm. Yeah, so very helpful for endometriosis as well.
I have a question about reading it.
Yeah. Oh, yes.
So we get it all the time.
Yeah.
Our clinic, they get the implant and coming. It's not typically like heavier periods, but just spotting.
Constant spotting, right?
So what
Yeah.
we do is we'll either give estrogen or
Yep.
just one pill pack to
Yep.
kind of
Yep.
to build up a lining, shed the lining, and
Yep.
then usually it's okay.
Yep.
Do you recommend doing that multiple times to have it implant,
So you can actually. So you can have someone with a, if they want to keep their implant in for contraception, you can keep them like on a low dose of oral estrogen in addition to their implant for, I mean, I've seen it done for at least a year. So you can have them taking birth control pills on top of their implant, which is annoying because most of them probably wanted to not take a pill and that's why they got an implant to start. But it will help them offset the bleeding. And if they were really just wanting reliable contraception, at least they get to keep their contraceptive. Other things that have been, I mean, everyone's trying to find something that'll help the bleeding, and then the other, I mean, part of it's counseling, which I'm sure you know. And then I used to work with someone who had a Nexplanon, and I was like, yeah, but what about the bleeding? She's like, oh, I just buy black underwear. She's like, problem solved, It's like, I never noticed. And I was like, that's the other strategy, right? And it's about the person too, right? Because some people, spotting really doesn't bother them. Like they know it's going to happen and they know it's normal, but they know they have reliable birth control, so they're like, yeah, whatever. Some people, like, it drives them crazy to have abnormal bleeding. They feel like something's wrong, like it's, or it's a laundry problem. I don't know, but so a lot of it's in the counseling. But then at a certain point, I mean, if you're having spotting every single day, I think most people are not going to want to put up with that. It's a lot of panty liners, or black underwear.
Most partners are at least going to try it.
Yeah, I think so. Most people will try it, right? You try to like throw something at it, and maybe, you just need something to kind of help fix it for a little bit, and then they kind of get into a better spot. We'll try it. We'll try anything. Cool. Thanks, guys. Thanks for coming. We appreciate it.